Doing good. Grateful to be up this morning. Oh, there you go. Thanks, Ken. Got the sound effects going. Hi, Naomi. Good morning. You guys, look who's here.
Good morning. Good morning. I'm
Good morning.
home.
Yes, Naomi, one of the co-founders. She's always held down our digital footprints, community, just so many things. I'm just happy to have her. So we're going to get started because we have a full agenda today. And as you all know, we were committed to healing for change because that was the pivot that we all had to make, coming together, accelerating through a network and this shared concern that we all have, and we continue to refine and define that. So our Healing for Change team, I believe I see Ingrid. Ingrid, are you going to lead us today in our workplace wellness? Or are we waiting
I think we're waiting for Lauren.
for Lauren? Okay, great. Okay. Well, we can continue to do that. And a teaser, Naomi is going to walk us through our website upgrade.
Woohoo.
Woohoo! So I'm gonna Naomi, is it okay while we're waiting for Lauren? Can I drop the link to the website in the chat and encourage people to kind of start checking?
Absolutely.
Okay. So you can visit the website. We hope we addressed many of the issues about registering for the meetings and getting notes and information to us quicker, faster, all that good stuff. So check it out. And then questions and feedback, that's what we're looking for today. Come on in. If you're just getting here, come on in. You are in the general meeting of the Community Response System for South LA. I'm Cheryl.
Hey,
And
Cheryl.
hey, Naomi's back, you guys. She's home. I'm so excited about that. This energy is just what we need, I need, to keep doing what we're doing. And I see the beautiful Lauren has joined us from Epiphany Counseling. They've been with us since day one, being the amazing healing artists, therapists they are, and just responding to all our needs from children all the way up to older adults. So, Lauren, what you got for us today? You take the mic.
All righty. Good morning, everybody. And thank you so much for that lovely introduction, Cheryl. It's wonderful seeing everybody this morning. I hope everybody is doing great. Today, I wanted to do some affirmations. And so, if you're not familiar with affirmations, affirmations are words of encouragement, words of positivity, things that we say to ourselves to help us feel better, to get us through our day, for us to believe in ourselves a little bit more. And when we take the time to say these affirmations, it allows us to focus on us, bring in some positivity and uplift our mood. And so today I wanted to kind of take some time to do some affirmations with all of y'all. So again, get comfortable. Close your eyes, stay on camera, get off camera, whatever is most comfortable for you. And we are going to begin with one another. When we get to the affirmation part, you are welcome to say these affirmations out loud or just in your head, whatever is most comfortable for you. So once you are in a comfortable position, if you are able, place one hand on your heart and rest the other hand on your leg with your palm facing up. If you feel comfortable, gently close your eyes. Rest your tongue on the roof of your mouth and feel your jaw slowly start to unclench and relax. Relax your face, relax your shoulders, relax your abdomen, relax your hips, relax your thighs, Relax your knees and your calves. Relax your ankles and feet, and relax your toes. Now we will take a few deep breaths. Breathe in for 4 and out for 6. So let's do that together now. We're going to breathe in for 4 seconds. 1, 2, 3, 4, and out for 6. 1, 2, 3, 4, 5, 6. And every breath, you release anything that is no longer serving you in this moment. So again, we're going to breathe in for 4. 1, 2, 3, 4. And we're going to release for 6. 1, 2, 3, 4, 5, 6. Okay, let's continue. I would like you to imagine a time you felt extremely happy, a time that you felt loved and supported and cared for. How does that feel? Where does it manifest itself in your body? Hold this feeling with you as you listen to these affirmations and know that you have the ability to make yourself feel happy, feel loved, and feel supported. As you listen to these affirmations, repeat them back to yourself, either in your head or you can say them out loud. I am whole. I am loved. I am exactly where I should be. Each day, it becomes a little easier to speak and act kindly towards myself. I'm learning to give myself the care and attention that I deserve. Loving myself is a journey that I am committed to. I deserve to be loved. I am becoming more aware each day of the love that surrounds me. I can find joy in the simple things. Trusting myself is possible. I let myself imagine the future I deserve. I am learning to let go of what I cannot control. I give myself permission to do what is right for me. It is okay to set boundaries with others and focus on my needs. I accept my emotions and I let them serve their purpose. My worth is not measured by my progress. I allow myself to slow down. I choose to forgive myself and let go of past mistakes. Showing myself kindness and compassion is becoming more natural every day. And this last one, I want to make sure we all say this together. I am enough. I am enough. I am enough. Now, gently take another few breaths. We're going to take it in for 4 seconds. We're going to exhale for 6. So 1, 2, 3, 4. Exhale for 6. 1, 2, 3, 4, 5, 6. And when you're ready, open your eyes. I want to thank everybody again today for following along. I hope that you're able to take a few of these messages with you home today. It's important that you remind yourself of these things because we can go through our day a lot of the times and not say these sort of positive things to ourselves, but we all deserve it. We've been working really hard. We all are, taking care of the community and our families and things like that. So it's important that we take that moment to also care for ourselves. So again, thank you so much for your time today.
Amen.
Awesome. Thank you. That was simply amazing.
Thank you. Yeah.
If you want some of these services at your place, we say it every 2 weeks. You can request uh, Lauren and other members of their team to come to your place. So think about that for your next meeting. It sets a great tone, moving us closer and closer to being trauma informed employers. We're all learning what that means. So on the screen,
Before
we,
you run away, I wanted to say thank you for that one, Lauren, because a lot of times we go day by day by day, and forget to stop and think about how wonderful we really are and how far we have come. This is a perfect one. You know, as frontliners and people on the ground, we forget how great we are, and we need to take that moment. So thank you very much. Appreciate that.
Amen.
I'm sorry, Cheryl. Just had to put that one up.
Aw,
That was a
thank
good
you
one.
so much for that. Thank you, Joanne. I really appreciate you saying that. That is definitely an important note. So I'm happy this one really resonated with you. Thank you.
It's a journey, you know, and we forget.
yes, it's something to be said about creating a culture of alignment. That's what we're here to do, right? So I'm glad you guys are in tune and can't thank our wonderful, like I said, therapist team, the Healing for Change and Workplace Wellness. They're just doing amazing work. So if you need those mental health services, you're looking for that professional, this is a team that we recommend. I think I saw our guest come in, Susie, Dr. Baldwin. She's going to give us a talk about coercion and this whole other issue around violence prevention that's public health that's happening. But I wanted to give Naomi, we have at least like 10 minutes, maybe less. We need her to give a brief intro to walk everybody through CRSSLA.org. So Naomi, can you do that? And then would you agree to come back again in the very near future?
Sure. If you need it, I'm here for you.
Okay.
All right. This shouldn't take more than 5 minutes because we're not going to be reading any text. We're just going to go through it and show people, show everyone the features that are there. But can I ask a quick question? If you look down at the bottom and look where it says, I want you to raise your hand if you've already seen the website. Just raise your hand. Click on the reactions at the bottom and raise your hand. We just want to see who has already seen the website. I don't know how many hands that is. We get some thumbs up there. Okay. All right. So website is here. Cheryl contacted me and she definitely wanted to upgrade the past one. She heard your voices, a number of people about the calendars and just a number of things. You wanted it, so it's here. So Crystal.org, we also got that URL back, and I got to give my son Timothy credit for that because he worked with me on it. He's the technical person, so he was able to get the .org back. So we actually have .com and .org. Either way, you're going to get here. So here's our homepage, and there's a number of features on here. I just want to point out the first one, of course, is the join button. This is where we wanted this to be up front, for people to be able to go right there. They can click on the involvement form right there. So this is what you're going to tell people when you're inviting them to come to Chris, so they can click very easily on that involvement form and fill it out. Go back to the home page. You can click on the logo at the top. We got our donate button. If you click on that, it goes right over. You can click on that and it goes to our PayPal page. Again, going back to the home page. So Cheryl, Brenda, and a couple of other staff that mentioned some things that that you all want as the priorities. You want to be able to access them right away. So those things are our ACH project, So you just click on that and you should be able to go to the page, but it's not going. So that's one thing I've got to fix. Something happened there because it was working. But anyway, I'm going to go back and fix that. But you should be able to click on that, go to the ACH page, go to the reports, volunteers, interns, general meeting, education, and justice committee. So for instance, I just clicked on it, go to the education. Again, the involvement form is there. It tells you when the meetings are, how to join the meetings, which if you click there, it takes you over to the calendar. You can look for the meeting on the calendar, click on it, and you'll be able to RSVP, which certainly a number of you did. So again, but everything that's on the home page, all of those pictures, they're also at the top menu, so you can find them there as well. So things like the history page, and a lot of us, even those of us who have been here from almost the beginning, there's actually a lot in our history that I never heard until I interviewed Robert and Cheryl. So there's some information here that you may or may not know. So that's kind of fun to read and get the background. Our leadership, if you're on the leadership, your name is probably here. If it's not, and it should be, let us know. So again, same for the partners. If you're a partner, your name should be here. We also added a link so people can reach out to you. Our donors are here. And then our news page. So anytime we're making the news is something we want to post. This is actually probably the first media event we had. This was way back in 2020 when we were announcing CRSSLA. So we put that up there. But then links to other news postings are also there. Also, let's see, under resources, these are some new pages. So we are the community response system of South LA. We're all about, emergency response and recovery, right? So we added a emergency page. So whether or not you're dealing with wildfires, whether or not you're dealing with any disaster in your community, the resources that you need are right here. So you can just go to crsla.org/emergencies. You got information on FEMA, the Red Cross. There's some great pages that we found on emergency preparedness, great flyers. It's all here. So now you can come here and hopefully get the information you need all in one place. In addition to that, we're all about organizing. So Cheryl really wanted to make sure that we shared that information. So if you're on a committee, even if you've been on a committee, for years, we highly recommend you go to this page. There's some great information on here about organizing. If you've ever felt a little frustrated and not quite sure, how to go about making change, the one-on-one basics are here, but also there's a couple of places here that you can go to get information, more information on how to become an organizer, as Martin Luther King, Rosa Parks, and Dr. Ralph Abernathy, all three of them are at Highlander. They went to school to become organizers. And as we know, the civil rights movement came out of that. So information for you to get that same type of training is on this site. Last couple of places, referrals. So again, we're about providing resources for people. So if you're looking for funding, if you're looking for, health information, legal, training opportunities, etc., there's a lot of information up here for you to get that information. If you have some referrals that you think we should add up here, again, let us know because we want to be able to grow this list with your help. And then reports. So all of the reports that we have so far for CRSSLA are up here. Of course, we'll keep adding to it. And then last but not least, the calendar page, as we already saw, and then contacts. When you click on that, it goes all the way down here. And we actually broke it out so that you can just click and get a drop-down menu for whoever you want to contact. If it's not up here, you can click on other. And then also you can give a subject, whether or not it's suggestions or regarding the meetings, partners, give that, and then fill that out. And then that email goes to Cheryl and the staff at LAM. And then if you're not on the e-newsletter or somebody you know is not, they can just go right here and complete it. And that is it. That is our website. Any questions, suggestions? as a matter of fact, we can use this contact form, if you do have suggestions, because we don't have a lot of time now, but if you do have suggestions, feel free. Cheryl, should they send it to you? Just click on network lead
Yeah,
or
they can
operations
just
manager.
operations manager or
All
even
right.
other, and someone will respond. We've got a lot of people reassigned, so
Okay.
yeah, we'll be able to get to you guys right away. Thank you for your patience.
All right. So
And
just click on other and then just click on, suggestion or question, and then let us know, because the intent is that it's a work in progress. It's out here for you to review and to respond. So let us know what you think. So if there's no questions, we're all done.
Looks good. Looks good.
Thank you, DangerMan. Nice to see you.
Nice to see you as well.
Quick update for those who don't know, I'm actually living in Texas. The picture you see behind me is my grandmother's land in Mount Enterprise in East Texas. I'm living not far from here, and I retired from the Wooten Center, largely for health reasons. I'm okay, I'm better, but I had to take a break, and part of that break was moving to the country. So I'm out here with the thunderstorms
Wow.
and the cicadas, thugs, and all that kind of stuff. But it's really cool. So, um, but um, but I feel much better now, so I'm able to do more work, and so I'm back home. So,
Great. Great.
all right.
all right, well, thank you, Naomi. We appreciate you so much. I dropped her information in the chat, and stay in touch with her because we continue to need her to help us sustain our work. So speaking of sustainability, I'm so excited to turn it over to Miss Bernita. She is our Justice Committee Chair, and we decided to bring that meeting following to this general meeting because we felt that the Justice Committee would be beneficial to the general membership. So that's what we're here, and we're kicking it off with one of the top public health executives, Dr. Baldwin, Susie Baldwin, and she's here to share with us some good links and information. So, Miss Bernita, would you like to introduce her? And I've put some of that in the chat already, and take it away.
Of course, of course. Good morning, everyone, and thank you for being here and having an open heart to receive this information. For those of you who don't know, I work in the field of domestic violence and intimate partner violence and gender-based violence. We're going to get all that into one package one of these days. And we also recognize that most of the issues that we go through day to day, starting from birth, are because of the issues that come out of domestic violence, intimate partner violence, and gender-based violence. Most people don't understand that. But when you hear what's going on, then you go like, oh yeah, that did happen to me. So I am a survivor, and Susie and I have known each other for a long time. For a long time. So I'm very, very grateful to be able to present her to you and the information that she is going to be sharing. If you would like to, you can, I don't know how many of you know, you can actually copy the transcript of what's going on, everything that's being said, if you go into your closed caption area. And that's what I choose to do so that I don't miss anything. So I just want to thank you, Susie, so much for accepting my invitation to come and share with us. We're working in health here, and you are a part of the Department of Health of the County of Los Angeles. So without further ado, I present to you my friend, the Dr. Susie Baldwin.
Yeah.
Thank you, Bernita. And thank you all so much for having me today. I'm really honored. And the website looks beautiful. It's really sharp, very impressive. So yeah, this is, I feel like it's a little bit of a jarring shift to this topic. I wanted to ask you as a group, have you had an educational session before or conversations about domestic violence or intimate partner violence in this group? Not really, huh? Okay, so go ahead, Cheryl.
I said just a little bit, not like where we're heading now. Bernita has convinced us we need to better understand as other social determinants and health providers. We have that full range, and so we're learning how important it is to keep connecting these dots. So I'm looking forward to hearing and looking over some of your links you shared. It looks pretty important. So yeah.
And Susie,
it is important. Yeah, go ahead.
we do have several individuals who have gone through the 40-hour training who are on also. So we do have that part.
Okay, great. So I'll be talking about one aspect of interpersonal violence, of a part of intimate partner violence. This is really part of a broader spectrum, and we do think of exposure to violence as a social determinant of health that can affect people, as Bernita said, really from in utero all the way to old age. We actually have a group now in our office that's working with partners on later in life intimate partner violence. So I'm going to give you a little bit of a background on domestic violence in general, and then we're going to focus on one part of it that's known as reproductive coercion. I'll share my slides. So this is really at the intersection of reproductive and sexual health, and okay, just share my screen first, and social health or healthy relationships, or in this case, we'll be talking about unhealthy relationships. And these have profound effects, as you can imagine, on people's physical health and their mental health. And I just was, let me share my screen and then I'll keep talking. Having a conversation with my sister last weekend, and she didn't realize that domestic violence is not just when somebody hits you or pushes you or assaults you. It's actually, it can be emotional and verbal, and that's a very common form of it that people don't even realize is considered abusive. So we'll start off with this. How common is intimate partner violence? Unfortunately, in our society, it is very common. This is a measure from over 10 years ago from the Centers for Disease Control, and it found that 1 in 7 men and 1 in 4 women in the United States report experiencing severe physical violence by an intimate partner sometime in their life. So that's one form of violence, is severe physical violence. We can also, but 1 in 7 men, 1 in 4 women. Another way it was measured also by the Centers for Disease Control is a survey they used to do called the National Intimate Partner and Sexual Violence Survey. The last year we have information from is, again, we're getting close to like 8 or 9 years ago. And that study found that looking at a broader definition of domestic violence or intimate partner violence, 1 in 2 men, and can't see this slide because of the, there we go. And more than 1 in 2 women, half of women and 2 in 5 men reported experiencing contact sexual violence, meaning not just harassment, but actually somebody touching them, physical violence and or stalking victimization by a partner at some point in their life. And then another way of looking at it, and this is more recent data, when we think about non-physical and non-sexual forms of violence between people, quite a few adults in our county reported ever being called names, insulted, humiliated, or intimidated by an intimate partner. About 10% of men, 17% of women, transgender women, over half of them, and people who identify as gender non-binary or gender non-conforming, or queer, they also were approaching 50% had experienced this sort of what we call verbal, emotional forms of abuse. So we're looking at a whole spectrum of the way people can be harsh to one another. And I also want to acknowledge that it can be upsetting. This could be something that's happened to you or somebody you care about. And if you start feeling anxious because this is triggering memories in you or just makes you uncomfortable, feel free to just step away from the computer, do what you need to do, because this is a tough topic. So one other form of harm that happens in intimate partner violence is called reproductive coercion. And this is when a person who's in the relationship is denied the ability to make decisions about their own lives and bodies in matters related to their reproductive health. We define it as any behavior that seeks to maintain power and control over someone's reproductive health, including attempts to interfere with contraceptive use, pregnancy decision-making, and protection from sexually transmitted infections. And it can involve force, verbal threats, pestering somebody, like just bugging them. It can involve tampering with birth control methods or any other actions. And whether or not this involves actually doing something physically with somebody's stuff or just pestering them, saying things to them over and over again, that is all still considered abusive behavior. And I'm going to move us a little bit into some language definitions to put this in the context of reproductive health, reproductive rights, and justice. So reproductive health, as defined by the World Health Organization, is a state of complete mental, physical, and social well-being, not merely the absence of disease or infirmity, in all matters related to the reproductive system and its functions and processes. Reproductive rights is the power of people, the freedom that people have to make their own decisions about their bodies, have a right to accurate information. So education about our bodies and our reproductive capacity is part of that right. Have access to reproductive healthcare services and decide if people want children or not. And then perhaps the most important definition is reproductive justice. This definition was this term was created by a group of Black women who got together and empowered themselves because they were being left out of the general white-led women's reproductive health and rights movement in the 60s and 70s. And this organization was based in the South. They're called Sister Song. You might be familiar with Loretta Ross, who was one of those amazing women. And they took a broader definition of reproductive health and rights that we use very frequently today. Reproductive justice as the human right to maintain personal bodily autonomy, have children or not have children, as is recognized as a reproductive right. But they added to parent the children we have in safe and sustainable communities. There's just little things on my screen that block me from seeing my own words. And parent the children we have in safe and sustainable communities. It's informed by past reproductive injustices. So we want to take the context in which people live, in which women of color live, and look at it broadly, because reproductive health is tied to everything around us. Okay, so here are some examples of reproductive coercion. This is when it gets a little bit more delicate. So we have something called birth control sabotage, which is when a partner interferes with the other person's birth control without their consent. And these include some things that maybe you haven't heard the terms of, but one would be a partner who refuses to wear a condom. The other would be when a person removes their condom without the partner's consent, and this would be called stealthing. So for example, if this would be for a heterosexual couple and the woman wants the male partner to wear a condom and he agrees, but he secretly takes it off, thereby jeopardizing her health, both exposing her potentially to an infection or to a pregnancy that she may not want or be able to handle right now. Destroying or tampering with birth control pills, rings, patches, or an intrauterine contraceptive, withholding money for birth control purchases, failing to pull out. Pull out is also known as the withdrawal method of contraception, where you start having sex, but the male partner removes his penis from the woman's body before he ejaculates. And it's not a very effective method of birth control, but it is something that people commonly use. So saying you're going to do that and not doing that is considered reproductive coercion. Another form of it is blocking access to healthcare. And that is, of course, something that can happen in abusive intimate partner relationships. It can be not only reproductive health care, but I had a patient whose partner denied her access to her asthma inhaler. And, we know that domestic violence can be lethal. We usually think of those cases as violent deaths, but it can also be from neglect of health, denial of medical care, and denial of medication. Going back to the reproductive aspects, applying pressure in pregnancy by trying to control the outcome of a partner's pregnancy by telling them what you think they should do, even if they don't agree, and instilling in them a sense of fear, powerlessness, or hopelessness. We think about domestic violence in general as the use of coercion and control. That's the big umbrella. So all of this stuff around reproductive health happens in the context of coercion and control, making somebody do what you want them to do, regardless of their own needs, their own mental health, their own physical health, their own decision-making. And what this sounds like is a variety of things to the person experiencing it. It's not about reproductive coercion is not about forcing somebody to have a baby or forcing somebody not to have a baby. It is the whole use of control. So I don't want you to use birth control. If you have an abortion, I'll leave you. If you don't have an abortion, I'll leave you. If you love me, you'll have a baby with me to prove that. And more now, because Roe v. Wade, which established people's right to have an abortion in this country if they wanted to, at certain stages of pregnancy, people are using state laws to further threaten their partners when they're in an abusive relationship. So if you have an abortion, I'm going to tell your family, I'm going to tell your friends, I'm going to shame you, or I'm going to tell the police, because now that may be illegal depending on where you live. Naomi has moved to Texas, and I hope you're going to do well there, but Texas has some of the most draconian, scary laws in the country around access to reproductive health care. And that is a place where you can get in big trouble for even talking about deciding to end a pregnancy, regardless of your reason. So how common are these forms of reproductive coercion? This is again from an older survey. They did not repeat this question, but they found that almost 10% of men and 8.5% of women reported reproductive coercion. And that's like sort of a surprising statistic, right? Because when you define this to people and say, how did your partner induce you, control you into trying to affect reproduction, men reported that a partner tried to get them pregnant when they didn't want her. That a woman got pregnant when they didn't want her to. So that's sort of flipping what I'm saying about reproductive coercion, but it does go both ways, right? A woman can control her body and decide if she's going to get pregnant. And the men in the survey felt that their rights were being taken away because now they are being essentially coerced into being a father. And then when you look at men compared to women with condom use, women reported a higher rate of saying that their partner refused a condom versus men saying that about women, which also makes sense. And then going back again to our current situation in the United States, where Roe v. Wade was overturned. We're going to be close to 3 years since that happened. That Supreme Court case was called Dobbs versus Jackson Women's Health Organization out of a clinic in Mississippi. And calls to the National Domestic Violence Hotline, they ask people what's going on in their relationship. Why are they calling? Why do they need help? And twice the number of people were reporting reproductive coercion once the law changed. So this shows how our policies, whether at the county level, the state level, the city level, the national level, can impact our lives on the ground. So abusers were realizing that the woman in question didn't have any more power, and were using that further to intimidate and scare people. And people reported this when they called for help. So jumping to another topic, it's important to realize, since you're all involved in healthcare, that we have very progressive laws in California that are based on scientific evidence. People of any age can access birth control or pregnancy-related care without a parent. And these laws to allow children access to sexual and reproductive health care, again, they're based in scientific and medical evidence that shows that giving minors access to this care is good for their health, and that kids who are in a situation where they don't have a trusted adult to talk to need to be able to access services from other trusted adults. The behavior doesn't stop just because you deny kids care for it. So again, like thinking about sexual activity among teenagers is kind of controversial. It's very hard for parents to think about their children in this way, but about half of kids do have sexual intercourse before they graduate high school, and California allows those kids to have safety in regard to their sexual behavior. So they can access birth control, and if they get pregnant, they do not have to go to a parent to get access to that care. And then for sexual health care, they have to be 12 or older to receive STI testing and treatment. They can get vaccines that prevent sexually transmitted diseases like human papillomavirus, which causes cervical cancer, hepatitis B, which can cause a lot of damage to the body. We all get that vaccine as infants now. I mean, not me, but those of us who have been around a while, but babies have been getting that for a long time. But if somebody hasn't, they can consent to that starting at age 12 for their own protection. And this also brings us to the importance of healthcare for survivors of intimate partner violence. Make sure I'm not going fast enough. Okay. So getting access to healthcare as survivors of domestic violence or intimate partner violence is a really important part of maintaining health and recovering from the impacts of abuse. So people who work with survivors have to know about how to link people with healthcare. And the laws in California allow changes to health insurance if somebody reports domestic violence. So if you get married, you have a baby, you can make changes to your health insurance that otherwise you have to wait till like October to December or whatever your plan allows you to make changes. But if you are experiencing domestic violence, you can make a change at any time during the year, which can allow you to get the health care that you need. We have Confidential Health Information Act that allows people to keep their health information separate, even from their partner, if they're getting insurance through their partner's plan. Just has to be requested through a confidential communications request. And we also have other privacy protections in healthcare in California that benefit survivors of intimate partner violence. It's all of our right to know how our doctors and nurses and nurse practitioners will use our personal health information, and we can say who does or does not have access to it. In abusive relationships, sometimes the controlling partner will have access to the medical records. Like if you have a portal from your healthcare provider, sometimes the abusive partner has that access. So if you were to go to the doctor and admit that somebody was hurting you, your partner could potentially log in and see that unless the doctor's office knows to keep that out of the portal. And we all have the right to request that, but most people in these situations don't know and aren't thinking about that. So as for those of us who work with clients and patients, it's our job to let people know who may disclose to us that they're in a violent relationship, that they have the right to protect this information for themselves and help them do that. I'm going to speed up a little so we have time for conversation. So another piece of information that's important for people who work with survivors of intimate partner violence is letting them know about contraception. Avoiding a pregnancy when you're not ready to deal with it, when you are in an abusive relationship, when you're trying to manage keeping your other children safe, it can be very important for people to prevent getting pregnant. And we have lots of options for this in California. It is covered under all of our health plans. So we want to make that connection for people who may not make it for themselves. This talks about the coverage. Of course, Medi-Cal covers all forms of birth control. Family Pact is another healthcare program for people with low incomes that covers all kinds of reproductive and sexual health, including HPV vaccination. And it also can be used for people who have insurance, like a private insurance plan, but are worried about confidentiality. So even though you can, through a private plan, say your job gives you Kaiser, but your partner who is hurting you is also on Kaiser, you can maintain confidentiality by going through a bureaucratic process, but you can also go to a healthcare provider, a clinic, and sign up for Family Pact, which is family planning access to care and treatment, and use that for your family planning services. That way, if you are trying to avoid a pregnancy while your partner is wanting you to have a pregnancy, they would never get a statement in the mail saying you visited this OBGYN on this day. So it's another way to maintain confidentiality. So I also want to explain that reproductive coercion is associated with unintended pregnancy, which is a pregnancy that the person doesn't want, or maybe they do want to be pregnant, but this is not the right time in their life. And as you can imagine, people with unintended pregnancies are the ones who are most likely to seek abortion. Of course, we also see people seeking out abortion when there is something wrong with the pregnancy, when there's something bad happening with the fetus, or sometimes with their own health, like if you get a cancer diagnosis in your pregnancy and you can't get treated. There's of course very complicated reasons why people will seek to end a pregnancy through abortion, but the most common reason is that the pregnancy is not wanted or the wrong time for them to be able to care for a new child. People also will say that being in an abusive relationship is a reason for seeking abortion, that they do not want to expose their kid to violence, that the baby will bind them to an abusive partner. And we know from studies of why people choose to have pregnancies versus carrying them to term and what happens to them later, that it is true that having a baby does keep some women in relationships that they otherwise would have left that can be harmful to them and to the children, actually. We also see this concern in human trafficking survivors who are, of course, being controlled by somebody else in terms of what they can do with their body, with their labor. In those cases, again, as with abusive partners in an intimate partner relationship, they control the person's reproductive decisions. They use the child or the baby as another form of control. And very sadly, the leading cause of death for pregnant women is homicide from intimate partner violence. We are dealing with a lot of problems with maternal health. I'm sure you guys are aware of this in South LA, with African American and Black women in this country experiencing shockingly worse outcomes than white women. And you're probably familiar with our African American Infant Maternal Mortality Initiative through the department, really making strides to empower communities, bring community peer support and protection and prevention, and trying to do something to get Black women better care in labor and delivery. So this is already a very fraught area for women of color, Black women in particular, and also Native American women. And having a domestic violence situation on top of a pregnancy that can lead to something devastating in the end when you're so excited to start your life with your child and instead things go wrong. This all ties in together. We look at people holistically and what's going on in their lives. The other time of a domestic partner, intimate partner relationship that is violent when things go wrong is when people try to leave. So you can imagine if somebody is pregnant, which is a risky time in an abusive relationship, and they're trying to leave their situation, that can cause them to be harmed and even lose their life at the hands of the violent partner. So I mentioned earlier that reproductive coercion has potentially increased with state control over people's reproductive decisions. And this is also borne out in research where the number of calls to the National DV hotline have doubled since, I think I had this slide earlier. Sorry about that. Okay, so then getting to our resources, this is our reproductive coercion guide on our website, which is the Abortion Safe Haven website, where we're trying to increase access to information and services for people who have a pregnancy they're not sure they want, or who have decided they do not want to be pregnant. And this, we got requests from our DV partners that they don't really know how to talk to people about sexual health, about reproductive health, in the context of all the amazing services that our DV agencies provide. So with their input, we created this a couple of years ago. And this is part of our Abortion Safe Haven pilot project, which was passed in 2022. And as Supervisor Mitchell said, it's important that LA County be a safe haven for women seeking abortion services. It's our duty, particularly those who have been historically underserved in Black and Brown communities. So as the county, we see access to abortion, like access to all healthcare, as a health equity issue, that people should be able to decide on their own what they want and get the service that they need, if it is what they need. I also know this is a controversial topic, but I threw this in because there's a lot we have in common across all of our religions about the right to reproductive health and reproductive justice. This is a book, I think it's like 20 years old now, but I was really fascinated by it when I found this, how scholars reading the texts of major world religions all found some commonality for choice. And if you're interested in learning more about the Abortion Safe Haven project resources, this is our website. And I'll pause. This is also another great resource guide we have for survivors of violence. We have this in 12 languages, including English, and things are marked by whether they are a better resource for DV, for sexual assault and sexual violence, or human trafficking. And thank you for your attention and your time.
Wow.
Bravo,
Amazing.
bravo, bravo.
Thank you.
Yeah,
Thank you.
love it. Love it. We have one comment in the chat, Dr. Baldwin, that asked if the PowerPoint can be shared. It has some great data. Is that something that you can share with us?
Definitely. I will, it's a little updated from last month, so I'll send you that PDF. And also, we are in the process of completing a couple of reports on data on intimate partner violence. They should be out in the spring. So we have new data from the LA County Health Survey. And we also have a report on others, like it's called a DV Data Sources Report, about all the places you can look for different estimates of DV from the police, from the hospitals, from surveys. It's actually very complicated to measure this because you can ask people in a phone survey, has this ever happened to you? And then you can measure the number of people who call law enforcement, the number of people who call a hotline, and they're all different pockets of people. And of course, some people never reach out for help and they never get counted.
Yeah. Well, we're here to help get into those hard to reach spaces. We like to think that's where our sweet spot is. And this information will arm us with the tools, so super grateful. Michael Browning is one of our community data partners. So Michael, do you mind if I ask you, what do you think about the data dashboard that Dr. Baldwin shared with us? I put it in the chat, and I was wondering, we were talking about
Alexa off. Sorry.
Oh, no.
Turning off Alexa.
Turn Alexa off for a quick moment. I was wondering what you thought about the data hub, because we were talking about this last week about we lost one of the public health data hubs that we rely on. And I just wanted to get your thoughts about the one that she just shared with us today. I'm going to put it in the chat again so you can see it.
No, I see it and I love it. And Just a quick update on the other one. I'm just getting back from Alabama from presenting at a conference, and so I'm going to get right back on that piece of the other dashboard. But I really love this, and this is what we're talking about, this type of collaboration, and it's much more user-friendly than some of the others. And I do have suggestions and so forth on it, but I think it's a great, great tool.
Yeah, yeah, it gets us back on track. We were just meeting on this last week, Dr. Baldwin, where the county had, I guess, maybe temporarily taken down the dashboard, and we were thinking about writing them a letter
Completely
because we
taking it down.
complete right. It was gone completely. And is it
Which
still
dashboard?
gone, Michael?
Yeah, the COVID weekly data report.
Oh, huh. I don't know anything about that. And these community profiles, that my first job in the department from 2006 to 2015, I worked on the LA County Health Survey data, which is where those interactive maps come from, but that is not my position anymore. I suggest for giving feedback to the department, it's the Office of Health Assessments and Epidemiology. I can definitely share that contact info with you, Michael, if you want to have a meeting and talk about what the community needs. I haven't heard anything about the COVID dashboard being taken down. We are not adhering to any executive order about diversity, equity, inclusion, gender. The county is proceeding to share data, and equity remains our North Star. We want everybody to have the opportunity to live healthy lives and feel safe and secure and well, regardless of what's coming out of DC right now, which is, I don't need to tell you, terrifying and maddening.
Absolutely.
Yeah. So I don't think it was taken down for that reason. I know some of the, we get billions of dollars as a county from the feds, and our public health funding is in major jeopardy, including the HIV STD data, where we do get that funding is federal funding. And here we are using it, as everybody has, to prevent HIV infection across the board. Transgender women have among the highest rates of HIV in the United States, extraordinarily high, due to their life circumstances. People who are trans, and particularly Black trans women, have very few options in life, and they have very high rates of HIV. And yet this administration wants to pretend these people don't exist. And we can't take care of them without the federal money. We can't take care of anybody without the federal funds for HIV prevention. So we may need to make some concessions in terms of what we say publicly to not lose the money we depend on. It's a very terrible situation to be in. But as far as I have heard, I don't believe that dashboard went down because of the racial analyses that we do, because I think we're continuing to do that.
I can tell you that the COVID site, what it looks like they've done is they want to consolidate it. So they moved the data over to a respiratory health web page. And so there's other information on there about the recent flu outbreaks and all of that. So they put it all on one. Yeah.
That does align with the reorganization in the communicable disease division, because COVID was our lives for years, and now it is one of the respiratory viruses.
Right.
That makes sense. Thank you for explaining.
That makes sense. Yeah. Michael, did you hear that?
I did. And of course, I went there and tried to find it, looked for about 3 hours, and the information that we need is not there.
Okay. Well, maybe we'll still follow up with the department to share that. That was a good exercise for both of us, for them and for us, to just have this open communication. That's what we're here for. They look for that feedback too, and I'm sure, fingers crossed they'll adapt. So we'll take that lead. Otherwise, we'll look it up ourselves, Dr. Baldwin, but if you can save us a little time, we love it.
I would love to share. So again, I'm with the Office of Women's Health. we are doing a lot of analyses on women's health data. So the main data analyses come out of the Office of Health Assessment, EPI, and then we work with them to produce lots of data around women's health. So later in the year, I can certainly share that with you. I see some hands.
Oh,
Yeah.
we'll take it. We'll take
Yeah,
it. Okay.
one quick thing before you leave. I know that you all used to put out an annual report on women's health that had the data reports. And I know it's been quite some time since you've done that. Is there a plan to continue that yearly data on women's health? Because that's really how Black Women Rally got started, based upon that data. And we haven't been able to update it for quite some time.
Well, so that comes out of the Office of Women's Health in partnership with the other Office of Health Assessment Epidemiology. So I've worked on both sides of that report. We didn't have any funding to make the report with the 2018 cycle, but all the data are on our website. So I should put that link in the chat. I'll send it to Cheryl to circulate. All the data are on the web. But this year we are making another report. It won't look exactly the same as the previous ones, but we can always give you the tables if you want every detail of the data. It sounds like, if you're a data person, you want the data by health district, by spa. That's not all going to be in the new report, but we're working on that right now. We're going to have a draft of it done by the end of June, and I guess it'll be circulated sometime this year. It's a huge project for us to get that data to you, and it will be in a nice report form again because we're doing the work internally, which we could not do during the pandemic. So all we have from the pandemic years are tables, not in a nice format.
All right. I think Miss Alberta, did you have your hand up next?
So Naomi's hand is next.
Okay,
down.
Naomi, I'm sorry, Miss
It's
Naomi.
down. That
Okay.
I already spoke. Yeah.
Mine is next. I'm so glad to hear you say about health data. I'm Cheryl Branch. I have aimed and one of the things I tried to do is, okay, who's pregnant in Los Angeles? I cannot find that data anywhere because for me, I don't know who catered my presentation to. I don't know if it's the 16-year-old are pregnant or the 25-year-old. Where do you find that? I'm like, Mike, I spent hours and I have actually tried. Do we who holds that? Hello, Jewel. Your information, and I appreciate where to go in our education when we're actually informing us. And, be able to put your hand right on it and give us the right. Make sure that our information is viable to the public. So where would I find that?
Joanne, it's hard to understand what you're saying. I think you're asking about teen pregnancy data?
No, pregnancy data, period. Who's pregnant? I can read so many things about birth, its outcomes, but it doesn't say, and used to always say a little breakdown of who's actually pregnant, and I didn't find that anywhere. That would be critical to what I'm doing.
You're right, it is hard to find that. We have graphs that are part of we have a training on why abortion is a public health issue, and we talk about particularly teen pregnancy. And looking at the percentage of teens who have had pregnancies over time, and we saw dramatic decreases. Getting the data in general, the best source would be, and I don't know if you're talking about for the county or the state or the nation.
County of LA, yeah.
Yeah. So the best contact for that would be Maternal Child Adolescent Health Division in our department. I think Diana Liu is overseeing that now. I'll put a list of these contacts together and send it to Cheryl to send to you guys, so you know who to reach out to.
You gave us your information, and thank you very much for that wonderful presentation. I'm one of Miss Bernita's 40-hour training.
Oh, great. Well, thank you for doing that and offering your services to survivors.
Okay, folks, we are at the end of our hour, 1 hour of power, 2 times a month and weekly on Thursdays for the health committee because they can't wait. But for all the other social determinants and the frontline workers, we appreciate you. We're here for you. The reason we meet is to give you the tools and the support that you need to actually serve the clients, the residents, the patients, the consumers that need us and depend on us so much. So I want to thank our wonderful guests. Look forward to building this relationship to help us better understand, because we know we got to diversify our funding, folks. And if we don't, we're going to struggle. It's going to be a challenge. And so we're here to support that part of our capacity building in this season of sustainability. And the information that Dr. Baldwin and Bernita are bringing to us is another resource, another take on these issues that we address, and we can all use this. So look forward to connecting and sharing. Talk soon.